Welcome back to the Deep Dive. We're the show that takes those huge stacks of source material and, well, makes them make sense.
And today we're tackling a really big one, medical surgical nursing. It's arguably the foundation of so much clinical practice.
It really is the core, isn't it? And our sources today cover, well, everything. We're talking quality, safety, the essential physiology concepts, right through to specialized care surgery, older adults, end of life.
It's a massive scope. The goal here is really to give you, our listeners, a clear path through all these connected ideas.
Exactly. We want this knowledge to stick. So we'll go from the big picture, like patient-centered care, all the way down to, those split-second actions you take in an emergency, and then back up again.
And it's important to remember the scale we're talking about. This is about promoting, restoring, or maintaining health for adults from 18, sometimes well over 100 years old. That kind of breadth really demands a certain way of thinking.
A professional mindset, for sure. And right at the heart of that are the core standards, the QSEN competencies. We should probably list those up front.
Good idea. These really govern everything. We've got patient-centered care, safety, teamwork and collaboration, evidence-based practice EBP, quality improvement QI, and informatics.
These aren't just buzzwords, right? They have to be woven into every single thing a nurse does.
Absolutely. They define competence. They're the mindset.
Okay, so let's start unpacking this framework. And where better to start than, well, with the patient. Patient-centered care, or PCC. It's more than just saying we care, isn't it? It's about recognizing the patient, or whoever they designate, as the one in control, a full partner.
It is, and that partnership means specific actions from the nurse. Research like that classic Frampton study really highlights things like showing respect consistently, acting as an advocate, and making sure the patient's autonomy, their self-determination, is always front and center.
But that ideal immediately bumps up against reality, doesn't it? I mean, things like healthcare disparities. How do we achieve real PCC? Well, we know some groups, maybe minority populations or the LGBTQ community, face barriers to access or just don't get culturally sensitive care.
Yeah, the sources are pretty clear on this tension. For PCC to actually work, nurses have to actively fight against potential bias. Take the LGBTQ population, for example. There's often a real history of mistrust there based on negative healthcare experiences.
Which means we can't just assume things. We have to ask the right questions sensitively to get a full picture.
Exactly. You need to integrate specific, non-judgmental questions. Things like, do you have sex with men, women, both, or neither? Or, if you have a sexual partner, have you or your partner discussed potential infection transmission? It's about creating that safe space to get the information you need for good care.
Okay, so once we've established that respectful environment, we're into the realm of ethics.
Right. And every decision, really, is guided by these core ethical principles. The first two often go hand in hand. Beneficence, doing good,
Right.
and non-maleficence, preventing harm, making sure the patient is safe.
That sounds straightforward, but I imagine sometimes doing good might involve something potentially harmful, like a painful but necessary treatment. That sounds like a conflict.
It definitely can be. And that's where advocacy and shared decision-making, respecting that autonomy we talked about, becomes so critical. The other principles help maintain the relationship. Fidelity, basically, keeping your promises, following through.
Okay.
And veracity, the obligation to tell the truth.
Veracity, telling the truth, seems simple. But what happens if a nurse, maybe trying to protect the patient, holds back some information? What's the immediate fallout from that?
Oh, it's corrosive. It just instantly damages your credibility. And that trust is everything in the therapeutic relationship. If a patient or family feels like they've been misled, even about something small, that trust is gone.
And then everything else becomes harder.
Exactly. Compliance goes down, anxiety goes up, and your ability to advocate for what the patient actually needs, even if it's tough, is just severely hampered. Veracity, being truthful, has to be the default. Hashtag TechTech 1.2, safety and quality improvement QI. And that principle of non-maleficence, preventing harm, leads us straight into safety, keeping patients and staff too free from harm, minimizing errors. Safety isn't separate. It really connects all the other QSEN concepts.
And one of the scariest safety issues highlighted in the reviews is failure to rescue, FTR. That's when the system just misses a patient going downhill. What are the key failure points there?
All right. FTR tends to break down in four main ways. First, errors of omission, stuff we just don't do, like missing a key assessment. Second, failure to recognize changes, not spotting those subtle signs that something's wrong.
Okay.
Third, failure to communicate those changes, the information gets stuck, doesn't reach the right person fast enough. And fourth, the final breakdown. Failures in clinical decision-making, maybe the team gets the info, but they don't act on it correctly.
Wow, that sounds systemic. If those points are so clear, which one tends to be the biggest hurdle on a busy med-surg floor? Is it missing things, or is it the communication piece?
Often it's the communication. Errors of omission, well, you can often fix those with checklists, right? Standard procedures. But communication, that's real-time transfer of complex information between different people, doctors, nurses, respiratory therapists, often under pressure.
Makes sense.
That's why we lean so heavily on tools like early warning systems, EWS, or EWSS.
Those are the scoring systems that flag vital sign changes.
Exactly. They turn numbers into a clear warning. And for communication itself, we use standardized tools.
Like SBR.
Yes, SBR, situation, background, assessment, recommendation, that's the foundation. But because communication still breaks down sometimes, you've got variations like ISBRR or SBRQ.
Okay, what do the extra letters add?
Well, the I makes the person identify themselves in their role, clearly. The final R demands a response or readback from the person receiving the information, closing that communication loop. And the Q prompts for questions.
So it's like adding safety checks to the communication itself, forcing active listening and confirmation so information doesn't get dropped.
Precisely. If basic SBR is like a standard car, ISBR is kind of like one with extra collision avoidance sensors built in.
Got it. And when things do go wrong, we don't just point fingers, we use quality improvement, QI. It's about fixing the process, not blaming people.
Correct. And the main model for that is systematic. It's the Plan, Do, Study, Act cycle, or PDSA. You plan a change, you do it, test it, you study the results, and then you act. Either adopt the change, tweak it, or maybe abandon it if it didn't work.
The sources also mention Focus PDCA. Why the extra steps in Focus? When would you use that?
Good question. It often depends on the scale of the problem. PDSA is great for smaller, more localized issues. But if you're tackling something huge, like, say, improving hand hygiene across an entire hospital system.
Right, lots of moving parts.
Exactly. You need those front-loaded steps in Focus. Find a process to improve, organize the right team, clarify what's currently happening, understand why things vary, and then select the change you want to test. That initial groundwork ensures everyone's aligned before you even start the PDCA testing cycles.
And that alignment is what leads to big wins, like that example in the sources about reducing CIQ catheter-associated urinary tract infections by, what was it, 46%?
Yeah, a huge reduction. And that saved money, sure, over $62,000 estimated, but more importantly, it reduced patient suffering. They used interprofessional teams, yes, but a key element was creating these CIUTI ambassadors.
What do they do?
These were specific RNs who really drove the process on the units. They enforced protocols like reviewing daily if a catheter was still needed, making sure insertion was sterile, providing immediate feedback. They weren't just auditors, they were the champions, the human engine making the QI happen. Hashtag 1.3 clinical judgment, systems thinking, and informatics.
Okay, so all this knowledge feeds into what nurses do moment to moment. Clinical judgment. The NCSBN definition calls it the outcome of critical thinking and decision-making, an iterative process.
Right, it's a loop. We can walk through that dizziness example from the sources to see how it works in practice using those 6 steps. Remember the patient admitted feeling dizzy, unstable when standing?
Yeah, okay. Step 1, recognize cues.
So the nurse sees the dizziness. Here's the patient report lightheadedness when they sit or stand up. The nurse also notes, crucially, the patient is 80. And they've been NPO nothing by mouth since midnight. Key cues right there.
Got it. Step 2, analyze cues and hypothesize.
The nurse thinks, okay, dizziness related to position change. Patient is older, likely dehydrated from being NPO. This points pretty strongly towards orthostatic hypotension as the main hypothesis. Maybe hypoglycemia or something cardiac. But the positional aspect is the big clue.
Step 3, generate solutions.
All right, if it's likely orthostasis, the priority is safety, preventing a fall. So solutions, keep the patient horizontal for now. Use a bedpan instead of walking to the bathroom. Make sure the call bell is right there. Tell the provider. Maybe ask for IV fluids or food if it's appropriate.
Step 4, take action.
The nurse does it. Helps the patient back to bed safely, puts on a fall risk bracelet, and then calls the provider using SBR. Situation, patient dizzy when standing, background, ADO, NPO. Assessment. Suspect orthostatic hypotension. Recommendation. Request order for orthostatic vital signs and IV fluids.
And then the final steps, 5 and 6, evaluate outcomes.
Right. The nurse goes back, checks the orthostatic blood pressures. Is the dizziness gone? Can they sit up now without the BP dropping? If yes, great. The intervention worked. If not.
Then you loop back to step 2, reanalyze. Was the initial hypothesis wrong? Should we check blood sugar? Look closer at the heart rhythm. That continuous loop is clinical judgment.
And it doesn't happen in isolation. That's where systems thinking comes in, right? Seeing your action with this one patient as the tip of the iceberg. Exactly. And realizing all the policies, protocols, staffing patterns, communication pathways, that whole underwater mass of the iceberg influences that action.
Which naturally leads to teamwork. Collaboration is essential with the whole team, RNs, advanced practice nurses, PT, OT, dietitians, social workers, pharmacists. It's a huge list.
It is. And a big part of that coordination is delegation. The RN assigning tasks to LPN/SVNs or assistive personnel, APs. But, and this is critical, the RN remains accountable for the outcome.
That accountability piece is huge. It means you have to follow the 5 rights of delegation religiously. Let's hammer those home.
Definitely. First, the right task. Is this something that can even be delegated according to policy and the delegatee's scope? Second, right circumstances. Is the patient stable? Are the resources available?
Sorry.
Third, right person. Is this specific individual competent and trained for this task? Fourth, right communication. Did you give clear instructions, limits, and reporting expectations?
In the 5th one, sometimes overlooked.
Yeah.
Right supervision.
Yes. Right supervision or monitoring. The RN has to follow up, check the work, provide feedback, and intervene if needed. You can't just delegate and forget. A classic error is delegating, say, the initial set of vital signs after surgery to an AP who's only trained for routine, stable vitals. That violates right circumstances and maybe right task.
And underpinning all of this, the standardization, communication, safety, is informatics.
Right. Using technology to manage information and prevent errors. The electronic health record, EHR, is the obvious example, standardizing how we document and share info. But think about safety devices, too.
Like smart pumps.
Exactly. Smart infusion pumps have drug libraries built in. If you try to program a dose or rate outside the safe limits for that specific drug, the pump flags it. Huge safety net.
And barcode medication administration, BCMA. Scanning the patient, the med, yourself.
Yep. It's that final check at the bedside, verifying the 5 rights of medication administration electronically. Delegation, safety. So much of modern nursing relies on these informatics tools working correctly.
Okay, we've got the framework. Now let's dive into those core physiological concepts that really drive med-surg care. Starting with circulation. Hashtag tag 2.1 fluid and circulation concepts, perfusion and clotting.
Perfusion, it's fundamental. Getting enough oxygenated blood flowing from the heart, that's central perfusion, and then making sure it actually reaches all the tissues and organs, peripheral perfusion. It's a spectrum, right? From optimal flow down to ischemia, where tissues aren't getting enough oxygen, and then infarction tissue death.
So what puts people at risk for poor perfusion?
Well, there are things you can't change, non-modifiable factors, like getting older, your genetics, maybe being male puts you at slightly higher risk for some things. But the real focus for us is the modifiable risks.
Things we can do something about.
Exactly. Smoking is a big one, immediate constriction, long-term artery damage, obesity, not being active, and then chronic conditions that aren't well managed, like diabetes or high cholesterol.
Let's imagine a critical situation, an arterial clot. How does a nurse spot that quickly? What are the signs?
You look for the classic signs, sometimes called the 6 Ps, though the assessment findings are key. The leg or arm below the clot will likely be pale, maybe white or mottled, and noticeably cool to the touch compared to the other limb. The patient usually reports sudden, severe pain. When you check pulses distal to the blockage, they'll be weak or totally absent. That's pulselessness. If it's progressed, you might find paresthesia, numbness, or tingling, or even paralysis.
And if you see that, what's the immediate critical nursing action?
First, hit the panic button, call the rapid response team, and notify the vascular surgeon immediately. Time is tissue here. And the absolute crucial thing, do not elevate that leg.
Why not? Instinct might say elevate.
Because elevation uses gravity to help blood drain away. With an arterial clot, you're blocking blood flow into the limb. Elevating it makes it even harder for any remaining blood to get down there. Keep the limb flat or even slightly dependent to help gravity pull blood in. Delay means potential gangrene, amputation.
Wow. Okay. Critical point. Now, shifting gears slightly to clotting itself, that balance between clotting too much or too little.
Right. Risk factors for increased clotting often involve stasis or blood changes. Immobility is huge blood pools in the veins, increasing the risk of a venous thromboembolism or VTE. Smoking, conditions like polycythemia, where you have too many red blood cells, and irregular heart rhythms like atrial fibrillation are also major risks.
AFib, because the blood pools in the heart chambers.
Exactly. Pools and clots and then can get pumped out. And for decreased clotting risk.
That's when you bleed too easily.
Right. Often it's about having too few platelets, thrombocytopenia, maybe from cancer treatments or sepsis, or the liver isn't working well, like in cirrhosis, because the liver makes most of our clotting factors. And then there are genetic disorders like hemophilia.
So the consequences are pretty distinct. Too much clotting
Leads to blockage. A clot in the leg veins, VTE, can break off and travel. If it goes to the lungs, it's a life-threatening pulmonary embolism, PE. If it goes to the brain, it's a stroke.
and too little clotting.
That means bleeding. You look for obvious signs like bleeding gums or blood in urine or stool, but also subtle things like petechiae, those tiny pinpoint red dots, or purpura, larger bruises, or just bleeding that won't stop from a small cut. Hashtag 2.2, respiratory and metabolic concepts, gas exchange and acid-base balance. Okay, next core concept, gas exchange. This is about getting oxygen in and carbon dioxide out. It involves breathing air in and out, ventilation, oxygen and CO2 moving across the tiny lung sacs, diffusion, and then the blood carrying it all where it needs to go, perfusion, if any step fails.
The body's in trouble. What are the main consequences when gas exchange goes wrong?
Two big threats. First, not enough oxygen gets to the tissues, leading to ischemia, potentially necrosis, tissue death. Second, you can't get rid of carbon dioxide effectively, and CO2 retention is a major problem because CO2 plus water makes carbonic acid in the blood.
Which leads directly to acidosis.
Exactly, respiratory acidosis, which brings us neatly to acid-base balance, maintaining that really narrow blood pH range, 7.35 to 7.45. Any deviation is serious.
So acidosis is pH below 7.35, alkalosis is above 7.45.
Hmm.
And the body tries to fix it, right? Compensation.
It does. It has two main tools, the lungs and the kidneys. They work to bring the pH back towards normal.
I always think of the lungs as the fast fix and the kidney as the slow, steady fix. Is that
Yeah.
about right?
That's a perfect analogy. The lungs can react almost instantly. Let's say a patient has metabolic acidosis, maybe from diabetic ketoacidosis, DKA, their pH is dropping. The brain senses this and tells the lungs, breathe faster and deeper.
Cuspal breathing.
Right, to blow off CO2. Less CO2 means less carbonic acid, which helps raise the pH back up. That's the rapid response.
And to the kidneys, the slow lever.
They take longer, maybe 24 to 48 hours to really kick in fully. They adjust how much bicarbonate, that's the base they either hold onto or let go of in the urine. In that same DKA example, the kidneys sense the high acid load and start conserving bicarbonate, reabsorbing more of it back into the blood to buffer the acid.
Ah, okay. So when you look at blood gas results, you're looking for signs of which system is compensating for the other.
Precisely. If the primary problem is respiratory, you look for kidney compensation, changes in bicarb. If the primary problem is metabolic, you look for lung compensation, changes in CO2. Hashtag 2.3, neurological and musculoskeletal concepts, cognition and mobility. All right, moving on to the brain and body. Cognition first, that's thinking, learning, memory, awareness. Problems here can be global, affecting everything, like delirium or dementia, or more focal, like amnesia after an injury.
What are the big risk factors for cognitive trouble in med-surg patients?
Well, advanced age is one, previous brain trauma, substance use, certain genetic things. But a really key one, often overlooked and sometimes reversible, is fluid and electrolyte imbalances.
How does, say, low sodium mess with someone's thinking?
Think about severe hyponatremia, really low sodium. Sodium is crucial for nerve signals. When it's too low, brain cells can actually swell. And the clinical sign you often see, acute confusion, delirium, the patient suddenly isn't making sense.
So the nursing intervention isn't necessarily a psych drug, it might be fixing the sodium.
Exactly. Recognizing that connection is vital. The intervention starts with safety. If they're confused, they're a fall risk. Then orientation for delirium or mild dementia, simple things like, you're in the hospital, it's Wednesday afternoon. Sometimes meds like cholinesterase inhibitors are used for dementia symptoms, but safety and addressing underlying causes like electrolyte imbalances are always the priority.
And the flip side of the coin, mobility. Purposeful movement, functional ability.
And the consequences of immobility are huge, even after short periods. The sources really hammer home 4 major life-threatening risks nurses have to actively prevent.
What are the big 4 threats from being stuck in bed?
Okay, number 1, VTE, blood clots from that venous stasis we talked about. Number 2, pneumonia, especially atelectasis, collapsed air sacs because patients aren't taking deep breaths.
Makes sense.
Number 3, pressure injuries, skin breakdown from constant pressure. And number 4, bone loss and muscle wasting because the skeleton muscles aren't being stressed.
So the plan here has to be really proactive, involving the whole team.
Absolutely. You need PT and OT for specific movement plans, but nursing drives a lot of the prevention. For pneumonia, teaching deep breathing and coughing, maybe using an incentive spirometer, getting them to do it every hour or two. For VTE, compression devices, maybe medications, and getting them walking as soon as safely possible.
And nutrition plays a role, too.
Big time. High protein helps maintain muscle mass and heal tissues. Fiber and fluids help prevent constipation, which is common with immobility and pain meds. Calcium and vitamin D help slow down that bone loss. It's a whole package deal.
Okay, let's apply these core concepts to some specific high-stakes situations common in med-surg, starting with something nurses deal with constantly.
Yeah.
Pain management. Hashtag 3.1, pain management.
And the absolute bedrock principle here, the gold standard, hasn't changed. Pain is whatever the person experiencing it says it is. Their self-report is the most reliable thing we have, even if they're older or have some cognitive issues.
We tend to categorize pain as acute versus persistent or chronic. What's the key difference in how they present and how we should think about them?
Acute pain is usually sudden, has an obvious cause like surgery or an injury, and it serves a purpose. It warns the body something is wrong. You often see those classic sympathetic nervous system signs: heart rate up, blood pressure up, breathing faster.
All right.
Chronic pain, though, lasts longer, typically defined as more than 3 months. It often develops gradually, and frankly, it serves no useful biological purpose. And here's the critical point. The body adapts. So patients with chronic pain might have completely normal vital signs or even low vital signs. Relying on vitals to assess chronic pain is a huge mistake.
Okay, really important distinction.
Yeah.
And the best approach to treating pain, especially moderate to severe pain, is often multimodal analgesia.
Yes. That means using 2 or more different types of pain relief at the same time. Maybe an opioid plus an NSAID like ibuprofen, or a nerve block plus something non-drug like heat or cold therapy. The idea is to attack the pain from different angles, which often means better relief with lower doses and fewer side effects of any single agent.
Makes sense. Let's talk opioid safety specifically. When we're adjusting doses, titrating, what's the guiding principle and the biggest red flag?
The goal is always the smallest dose that gives adequate relief. And while some opioids, the pure mu agonists like morphine, don't technically have a ceiling dose for pain relief, their side effects absolutely limit how high you can go. We also need to talk about a drug to generally avoid: meperidine or Demerol.
Really, meperidine's still pretty well known. Why is it discouraged now?
It's because of how it breaks down in the body. It produces a toxic metabolite called normeperidine. This stuff actually excites the nervous system and can cause tremors, confusion, delirium, even seizures.
Wow.
And that risk is much, much higher in older adults or anyone with kidney problems because they can't clear that toxic metabolite effectively. It builds up quickly. Honestly, there are just much safer opioid options available now.
Okay, good to know. The most feared side effect of opioids, though, is respiratory depression.
Absolutely. And the crucial warning sign, the thing nurses need to watch for, like a hawk, is that sedation comes before significant respiratory depression.
Ah, okay.
We use tools like the Pacero Opioid-Induced Sedation Scale, the POSS score, to track alertness. If a patient is getting harder and harder to wake up, maybe drifting off mid-sentence, that's your red flag. Respiratory rate dropping is likely next.
And if it does drop, say below 8 breaths per minute, that triggers the critical rescue, giving naloxone.
Right, naloxone or Narcan. But the action alert here is how you give it. You give it IV, but slowly.
Why slowly? Don't you want to reverse it quickly?
You want to reverse the respiratory depression? Yes, but naloxone slams the door shut on all opioid effects instantly. If you push it too fast, the patient goes from deeply sedated to wide awake in agony because their pain relief is gone, potentially having severe withdrawal symptoms, maybe even dangerous heart rhythms or fluid in the lungs from the shock to their system. Slow titration reverses just enough to get them breathing safely without causing that violent rebound.
Got it. And naloxone wears off faster than most opioids, right? So what's the follow-up?
Constant vigilance. You have to keep monitoring them closely because as the naloxone wears off, the opioid can take over again and cause respiratory depression to return. They might need more doses, maybe even a continuous infusion for a while. Hashtag 3.2, care of the older adult. Now let's focus on older adults who make up such a huge portion of med-surg patients. They have unique vulnerabilities. We often talk about the 3Ds of cognitive issues.
What are those again?
First is depression. It's incredibly common, probably the most common mental health issue in older adults, but it's often missed or just brushed off as, oh, they're just old. Second is delirium. That's the acute, sudden onset confusion that fluctuates. It's serious, a major predictor of bad outcomes, even death.
Okay.
And third is dementia, which is the chronic progressive confusion. And the key message here is Dementia is a disease process. It's not a normal part of getting older.
Since delirium especially is linked to poor outcomes, what's the absolute top safety priority for older adults in the hospital?
Falls. Hands down, falls are the most common accident. Stats say more than 1 in 4 older adults falls each year. So prevention is huge. This involves using assessment tools, maybe initiatives like the CDC's STEADY program, but also, critically, looking at their medications. Polypharmacy is a massive risk factor.
Too many medications.
Too many or the wrong types,
Yeah.
especially psychoactive drugs that can cause dizziness, confusion, orthostatic hypotension, all major contributors to falls.
And medication safety in general is trickier in older adults because their bodies handle drugs differently.
Absolutely. Physiology changes with age. They tend to have less total body water, so water-soluble drugs become more concentrated. They have more body fat, so fat-soluble drugs stick around longer. Plus, liver function often declines, so metabolism is slower, and kidney function decreases, meaning excretion is slower.
So drugs hang around longer and can build up to toxic levels more easily.
Exactly, which is why the mantra is start low, go slow. Begin with a lower dose than you'd use in a younger adult and increase it very cautiously, monitoring closely for effects and side effects. And we have tools to help guide this, like the Beers criteria.
What's that?
The Beers criteria is basically a list of medications considered potentially inappropriate for most older adults, either because the risks generally outweigh the benefits or because there are safer alternatives. It flags things like certain strong anticholinergic drugs, some sedatives, muscle relaxants drugs known to cause confusion, falls, constipation, etc. in this population. It's a really useful reference for medication review.
Okay. And for a quick bedside assessment screen for common issues in hospitalized older adults, there's the SPICES acronym.
Yes, Spices is a great little tool, easy to remember. It prompts you to check for sleep disorders, problems with eating or feeding, incontinence, new or worsening, confusion, again, new or worsening, evidence of falls, recent history, and skin breakdown. If you flag any of these, it triggers a deeper dive in specific interventions. Hashtag tag 3.3 perioperative care, the surgical journey. All right, let's walk through the surgical experience, perioperative care. It's a whole journey with distinct phases, pre-op, intra-op, post-op. We'll focus on the nurse's role in safety during the transitions.
Starting in the preoperative phase, assessing risk is key. We often hear about ASA classifications.
Right, the American Society of Anesthesiologists classification. It ranges from ASAI, a totally healthy person having elective surgery, up to ASAV, someone who is near death and isn't expected to survive without the surgery. And managing an ASI is vastly different from managing an ASAIV or V, where you're dealing with severe systemic disease and every step is high risk.
Informed consent is another pre-op must. Who does what here?
Okay, the surgeon is responsible for explaining the procedure itself, what it is, the risks, benefits, alternatives, potential outcomes. The nurse's role is primarily as a witness to the signature. We also clarify information the surgeon already gave, maybe bust some myths, answer questions about general care, but we don't explain the procedure itself.
And you verify the signature is obtained before any sleepy meds are given.
Absolutely critical. The patient must be fully alert and competent when they sign. If they suddenly say, wait, what exactly are they doing again? Or, I have more questions for the doctor. You have to stop everything, get the surgeon back in there. You're the patient's advocate in that moment.
And arguably the biggest pre-op safety rule. NPO status. Nothing by mouth.
Non-negotiable. The risk is pulmonary aspiration inhaling stomach contents when anesthesia relaxes the airway reflexes. That can be fatal. If a patient breaks NPO, even with a sip of water against instructions, surgery usually has to be delayed or canceled for safety.
We also use that pre-op time for teaching, right? Especially exercises to prevent post-op problems.
Yes. Vital for preventing VTE and pneumonia. We teach deep breathing and coughing, showing them how to splint their incision with a pillow makes coughing less painful, and leg exercises, ankle pumps, tightening thigh muscles. They need to understand why it's important and actually demonstrate they can do it. The goal is 5-10 repetitions every 1-2 hours while awake after surgery.
Okay, now fast forward. Post-operative phase. Immediate recovery in the PCU phase I. Priority number 1.
Airway. Always, always airway. Monitoring breathing, oxygen saturation, keeping SpO2 above 95% or their baseline, then circulation, watching for bleeding or signs of shock, and starting VTE prevention measures right away, like compression stockings or devices.
Post-op nausea and vomiting, PONV, is common. But what about that sluggish bowel issue, paralytic ileus or POI? Nurses listen for bowel sounds, but you said that's not the definitive sign.
Right. Listening for bowel sounds is part of the assessment. Immediately. Recognize it, stay calm, but act fast. Stay with the patient. Call for help, loudly get someone else to notify the rapid response team and the surgeon's stat. While waiting, cover the exposed organs immediately with sterile dressings soaked in sterile saline
Why so?
to keep the tissues moist and prevent them from drying out, which causes damage. Keep the patient lying down, usually supine with knees slightly bent to reduce tension on the abdomen. It's a true surgical emergency. Hashtag 3.4 end of life and rehabilitation. We also need to touch on care at the later stages of chronic illness, starting with end-of-life care. It's important to be clear on hospice versus palliative care.
Right. Hospice is specifically for a life-limiting illness, usually a prognosis of 6 months or less, focusing purely on comfort.
Exactly. Palliative care, on the other hand, is also about comfort and symptom management, but it can be given alongside curative treatments at any stage of a serious illness, regardless of prognosis. The goal is quality of life.
And respecting patient wishes is paramount, often through advanced directives, like the Durable Power of Attorney for Healthcare, DPO-AHC, that names a decision maker.
And the living will, which outlines desired or undesired treatments. And then there are specific orders like DNR do not resuscitate or the more detailed POL-ST forms. And remember that legal point. Without a valid DNR order, healthcare providers are legally obligated to start CPR if the patient arrests.
When managing symptoms like pain, shortness of breath near the end, families often get very worried about the patient not eating or drinking. How do we address that?
That requires really sensitive communication. We need to gently explain that decreased appetite and thirst are natural parts of the dying process. Trying to force fluids or nutrition can actually increase discomfort, causing fluid overload, more respiratory secretions, nausea. There's evidence that this natural dehydration might even release endorphins, promoting a sense of comfort. Reassurance is key.
And ethically, it's crucial to distinguish between active euthanasia, which is illegal,
And withdrawing or withholding life-sustaining treatments, like taking someone off a ventilator when it's clear it's only prolonging the dying process. That's often called allowing natural death. It's ethically and legally supported. The underlying disease is the cause of death, not the act of stopping the intervention.
Okay. And finally, shifting to the other end of managing chronic conditions,
Yeah.
rehabilitation. The focus here is getting people back to their best possible function.
Exactly. Restoring independence after illness or injury. We use assessment tools to track progress. The famed functional independence measure is one common one. It helps quantify how much help someone needs. We also look at ADLs versus IADLs.
Activities of daily living versus instrumental activities.
Right. ADLs are basic self-care. Bathing, dressing, eating, walking. IADLs are more complex tasks needed to live independently in the community. Shopping, cooking, managing finances, using transportation. Someone might be fine with ADLs, but need a lot of help with IADLs.
And a huge part of rehab for both patient and staff safety is safe patient handling and mobility, SPHM.
Oh, absolutely critical. Those no-lift or limited lift policies are there to prevent musculoskeletal injuries in staff MSDs, which are rampant in healthcare. It means using the right equipment, ceiling lifts, sit-to-stand devices, slide sheets based on a patient's mobility assessment rather than relying on manual lifting. It protects everyone. It's a core safety competency. Hashtag tag outro.
Wow. We have covered a lot of ground today, a true deep dive. We started with that essential framework, patient-centered care, safety, QSEN, using tools like SBR.
Right, laying the foundation. And then we connected those principles to the core physiology, how perfusion and clotting work, gas exchange and acid base, how fluid balance impacts cognition.
And then saw how all that applies in specific areas. Preventing falls in older adults, nailing down pre-op teaching and safety checks like NPO, handling emergencies like evisceration or knowing how to use naloxone carefully.
It really is all interconnected, isn't it? And if there's one big takeaway from this whole deep dive, maybe it's this. Effective, high-quality nursing happens when you see your actions, whether it's catching an early warning sign, delegating correctly, carefully adjusting a pain med, not just as tasks for this one patient right now, but as part of a bigger system. How your actions contribute to the safety and quality for everyone who comes after. It's that systems thinking, linking your practice to the bigger picture.
That's a powerful thought. Connecting the individual act to the system's health. Well, thank you for joining us on this really extensive exploration of MedSurg fundamentals.
Yes, thank you for learning with us today.
We'll catch you on the next deep dive.